BBC London 94.9.
Okay, so here's the thing. If your heart stops, ever since the 1960s, among other things, CPR, defibrillation, they give you an injection of adrenaline. Only now are they thinking they might not work. A, they might not prolong your life, and B, they might increase the likelihood of you suffering brain damage. Well, there's no point having an injection of adrenaline because your heart stopped if it's going to fail to prolong your life and give you brain damage, is there really? So the point is they need to do a trial. They need to see whether they work or not. How do they do that? They give some patients the adrenaline injection, and they give some patients an injection of salt water, which doesn't do any harm and doesn't do any good either. But they can't tell you which one you are, because obviously that ruins the whole point of the trial. And they won't tell the paramedics administering the injections either. They won't tell them whether they're placebo or not. This has been described as ethically challenging, a study into whether adrenaline works in resuscitation. Patients in cardiac arrest will receive either a shot of adrenaline, which is the current practice, or a salt water placebo. But neither the patient, their relations, nor the paramedic administering it will know which. The trial is controversial because patients will not be able to give consent to take part and could receive a totally useless placebo injection. Current guidelines used by ambulance services recommend routinely giving adrenaline during the resuscitation of patients who suffered cardiac arrest. However, there are concerns that adrenaline may cause severe brain damage and may not help overall with survival. It's a study led by Warwick University, and it has been approved. It's been approved. It's already rubber stamped. It will start in London, and the first 8,000 patients who suffer cardiac arrest will be included. So that means if it's you might get salt water instead of adrenaline. Oh my gosh. So what do you think of this? Do you think, well, good, okay, if it helps to work out whether adrenaline injections really work or not, I'm happy to be part of it? Or do you think, no, wait a minute, I want to be the person that gets the real injection. I don't want to be the person that gets the dummy drug. No, thank you. You'll have no say in it whatsoever. 0207 224. I don't know why I say you, we. Could be me. Hope it's not, but could be me too. I live in London. Could be me. Would I rather have the placebo or the real thing? Well, I wouldn't fancy brain damage. I do want to survive. Don't know, really. I suppose it depends whether the saltwater injection does no more harm nor good than the other one or not. And they could only find out by doing the trial. I don't know. Gosh, thinking about it. Hope you're thinking about it. I'm delighted that we can bring you Dr. Iqbal Malik, our favourite cardiologist. He's a consultant cardiologist at Hammersmith Hospital. I'm so glad he's joined us this morning. Dr. Malik, good morning to you.
Good morning.
Okay, well, we've had expostulations of outrage, we've had fulminations of disbelief, we've had all sorts going on so far. Ethically challenging is one of the descriptions of this trial, which has been rubber-stamped and is going to start in London, and I'm sure you know all about it. The idea is 8,000 people might get the adrenaline injection if their hearts stop beating, and they might get water with a bit of salt in it.
Okay, so thanks for the opportunity, because I think we do need to clarify what we're trying to do here. I'm not directly involved with the study, so I think I can speak independently about research.
Yeah.
Let's imagine a slightly sort of less hot scenario. You have heart failure, which I was speaking about yesterday, and imagine beta blockers, which are a very standard treatment for heart failure. Before they became standard, the trials that were done compared a chalk tablet to a beta blocker in patients with heart failure. Had that trial never been done, we would not now have a life-saving tablet, which is a beta blocker in heart failure. So the only way that we can move research on without any bias given by the doctor or the patient is to have placebo-controlled trials. So neither party knows.
And let me just ask, were the patients given the chalk tablets didn't know, and neither did the doctors administering them?
Exactly.
Right.
Because the only way you can be absolutely sure that the patient didn't feel better because of the power of the doctor's charm, and the patient didn't feel better because the doctor somehow biased the study, is to have no one but the trial coordinators know. And that is the best way of advancing patient care.
Right.
Now, I've heard the previous gentleman's concerns. I understand them completely. Of course, as soon as you get to not the stable heart failure population, but someone in the midst of a medical crisis, then there are very well recognized ethics about how you try and you can't consent them because they are unconscious. So any treatment that we do in that situation has to be well thought out. And just because it's been done since 1960 does not mean that it is the right answer. I'll give an example of something that we looked at the Hammersmith Hospital in the 1990s.
Yes.
We used to give something called magnesium as an infusion after a heart attack, and all the data suggested it was quite a good idea. And then eventually a placebo-controlled trial where we gave a sort of bolt injection versus a magnesium injection showed that all that thinking, all those small studies were actually nonsense, and there was zero benefit to it. Now, in this particular study, it's not that there's zero benefit. That Japanese study suggested it might actually be doing harm. So I don't think we're actually depriving patients of anything that has an absolutely proven benefit, because adrenaline got into the system in the 1960s and 70s because we had absolutely nothing else to do, and we saw a pulse come back, and that we thought was very, very useful. But of course now we're not that interested in the pulse coming back. We're interested in the patient going home and looking completely normal, if at all possible. So I think the premise of the study is absolutely sound. The higher the risk to the patient, the more important it is that we have a validated treatment. And this treatment has not been through that round of placebo-controlled studies. It's been around forever, and there has been accepted wisdom. That's where the evidence has come from. No evidence, accepted wisdom. Now this Japanese study really casts doubt on whether this is the right thing to do. And the only way to actually assess it is to do exactly what is happening, use our ambulance service, which are fantastic, and say, look, you will not know because you are in effect the doctor here. You will not know. The patient obviously will not know because they're unconscious. We will collect all the data, and we will then know for sure whether what we've been doing has just been hocus pocus, magic water, because nothing was beneficial and may even be doing harm, or whether in fact we can confirm now that this treatment really is beneficial and is not doing harm.
But if it is the adrenaline injection that gets the heart pumping again, and if the injection of salt water or sugar water or Ribena or whatever the placebo is doesn't get the heart beating again, and if it's shown that actually adrenaline was terrific and has worked extremely well and has been most effective, and that's why it's been used since the 60s, and the placebo's rubbish and all those patients don't get their hearts beating again, then various people will have lost their lives along the way because of this trial. And people will be thinking, okay, let's do the trial, but don't let it be my mother, don't let it be my sister, don't let it be my sweetheart, let it be somebody else, just in case the adrenaline really does work and has been working really well this time.
Well, the reason behind actually doing the study is because there is so much doubt about whether the adrenaline works. And
have you come to doubt it yourself in your practice?
To be honest, if it was my mother and she was picked up by London Ambulance, who are fantastic, I would have absolutely no qualms about her going into this study, because there is more than enough doubt about whether, forget the heart restarting, because I don't really care about that. Let's talk about whether she will get out of hospital in one piece. And I think the evidence at the moment is very shaky that we're able to achieve that with what we're doing currently. Apart from, if we're talking about just the adrenaline, there are lots of other things we can do around the cardiac arrest. But if we're talking about, does the adrenaline injection have that magic bullet effect that saves her life and gets her home? The answer is we are not sure. We're uncertain enough that the trial is very, very important. Personally, if my mum, God forbid, had this problem, I would have no qualms whatsoever about her going into the study, because she would be followed up meticulously, much more so than the average NHS patient afterwards.
Right. Well, when you say so, we're not so worried about getting the heart started again. You can imagine, to the lay listener, boy, are we worried. We want the heart starting again. We don't want it not to start again. What are the other methods up your sleeve to get the heart starting again without the adrenaline?
The main reason for survival when you have cardiac arrest is that you have a defibrillator handy so you can be shocked out of the rhythm. That is the most important treatment, and that is validated, and that is why coronary care units and ambulances and even public places have defibrillators. So no one's testing that. This is about an injection, and the benefit of the injection is in doubt. I mean, I think if I can be as open to say I'm happy for my mother to go into the study, and I do love my mother, then why would it be that other people who perhaps don't quite understand the concept of what this trial is about have a concern? I understand that concern, and I thank you for the opportunity to try and allay those concerns, because you mentioned surely it's about restarting the heart. And I would say for my mother, no, it's not. Because if she has her heart restarted for 5 minutes and still, unfortunately, is brainstem dead at the end and we can't communicate with her and she dies 6 weeks later, that's not a good result. If the heart didn't restart and she died, if the heart did restart and she died, and there was no difference in that hard outcome, then why would we give the injection of adrenaline? You know, the heart restarting was not the issue.
Right.
It's actually survival with some quality of life, and that is what is in doubt with the adrenaline injection.
Do you think too many of us have watched too many medical dramas over too many years, to the point that Terry, as you heard on the line there, said, well, I've watched Casualty, I've seen, ER, I've seen this, I've seen that for years and years, and there's always a moment where they get that injection and thump it into the chest wall.
I understand that. That's a very.
We've all seen it,
And can I give you my anecdote? When I was a medical student, I watched St. Elsewhere. I really enjoyed it. I could try and make a diagnosis.
Right.
I now watch ER with my kids, and I watch Dr. House with my kids.
Yeah.
It annoys the hell out of me, because actually what they do in those programs is not really real life. It's a stylized, it's a storyline. And so whereas before, as a medical student, I really enjoyed those programs. Now I find them very annoying because it's not really reality.
Do you think they're irresponsible?
No. They've got a story to tell, and I think we shouldn't be using those as our medical education. What we should be doing is to say that is great entertainment. It's giving us some information, but what it is not medical reality, and that's not how we should be educating our population. They're entertainment. They're not medical education.
Final question. How usual or unusual is it to have a trial like this that you don't sign up to, that you don't know you're taking part in, and that the paramedics involved in administering either the placebo or the injection don't know they're taking part in either? Is that normal?
That's completely normal. The only addition to this, and that happens with emergency patients, is that the patient can't possibly know because they're unconscious. Right. And that has been done before. There was a big trial that was done in Liverpool that was presented and really heavily discussed in cardiology, where they did exactly that. The consent was taken after everything had settled down, and if the patient refused, and in fact very, very, very few refused, they were excluded from the data analysis, but the trial was done in any case. And it's the only way to do a trial in a very, very sick patient.
Is this imminent, this trial?
No, that's already been published.
No, this one that we're talking about, today's trial.
This is starting now. 8,000 patients. Well, there are about 1,000 cardiac arrests in London per year, and so that the cardiologist would actually see. So I think the recruitment will take a couple of years, and then we'll find out what the results are. But this is an important study, and I would ask everyone to support it.
Thank you very much indeed. Thank you. That's Dr. Iqbal Malik. He's a consultant cardiologist at Hammersmith Hospital. He said he'd be happy for his mother to be part of this trial.